Can you see my slides or?
Oh, we are live, Andrew, and I am projecting, and then I will hand over to you, and then you can project from your side.
Perfect.
All right. Thank you so much. Welcome all to our November edition of the TB Think Tank webinar series. This session is titled Men's Vulnerabilities Across the TB Illness to Health Journey, Insights from a Mixed Method Study, and this will be presented by Prof Medina-Marino. An introduction to today's speaker. Prof Medina-Marino is the lead for the data-driven advocacy with the Rural Health Advocacy Project and TB Accountability Consortium. He is an adjunct associate professor in psychiatry at the Perelman School of Medicine, University of Pennsylvania, and he is an extraordinary associate professor in the Division of Molecular Biology and Human Genetics at the Department of Biomedical Sciences at Stellenbosch University. He's also affiliated with the Desmond Tutu Health Foundation. Andrew's work on TB has two main components. First, he seeks to understand and intervene on the social determinants and gender norms that impact men's engagement in TB care and treatment services. Secondly, he seeks to identify and implement strategies to accelerate community-based TB testing services using made-for-portability molecular diagnostic platforms. He has been funded by the US NIH, the Gates Foundation, and FIND. He holds a BA from Swarthmore College and a PhD from the California Institute of Technology. And with that said, I will hand over to you, Prof. The floor is yours.
Wonderful. Good morning, good afternoon, everyone. Can you see my slides?
Yes, we can, Prof.
Perfect. Okay. Okay, so today I'm going to tell you about the work that we've been doing on the intersection of men's health and TB. So I'm sure I don't really need to tell you much about the recent global TB report that came out, where they showed that in 2024, there were about 10.7 million people who fell ill with TB, of which there was a large proportion of those who were not diagnosed or treated, and about 1.3 million people died. When we look at those who fell ill, 54% of them are adult men, 35% adult women, and 11% were from those who fell ill were children. So we could see that there's a humongous burden of TB amongst men compared to women. And we also know that men are less likely to get tested, less likely to initiate treatment or successfully complete treatment. The image here to the right is just a graph of all of the TB national surveys conducted between 2009 and 2018. And you could see from all these countries, so this is showing the sex ratio of the number of cases in women compared to men. And in all the recent national TB prevalence surveys, men had a higher rate of TB compared to women, with Ethiopia having the lowest of, for every one case amongst women, there were 1.2 cases amongst men, to a whopping, for every one case amongst women in Vietnam, there were 4.9 cases amongst men. And South Africa's recent national prevalence survey identified that for every one case amongst women, there was about 1.6 cases amongst men. Okay, so this slide here shows the global burden of disease, and we could definitely see from it that men's health is definitely an overlooked dimension. So what's being shown here is in these rectangles is the disability adjusted life years, and disability adjusted life years is made up of two components of disease: early deaths due to the disease, and then the length of time lived with that disease. And what we could see here is that men, hands down, have the higher burden of disease, especially those due to early death, whereas women, for those that they have the higher burden, it's due technically to the number of years lived with that disability due to the disease. It's only amongst three main diseases that women have um, a higher rate of early death due to those diseases. One of them, which of course we all know, is HIV. The other ones are Alzheimer's and some musculoskeletal disorders. So, if we think about the global responses to HIV and TB, so from HIV, I don't think it's any surprise that we know that there's been an extensive, heavily funded, highly targeted global effort to reduce the burden of HIV. And a large portion of the work done is either this kind of universal access to testing, treatment, and prevention, but where there is targeted gender aspects, it is typically amongst women. And the rationale for this, which is logical, is historically there's been a higher rate of HIV amongst adolescent girls and young women, specifically in sub-Saharan Africa. So there's been a very fair, reasonable focusing of prevention treatment efforts amongst women. Now, unfortunately, we definitely do not see that same effort with TB. So with TB, there's definitely also been a large global response, though still insufficient, but there's been a response to the global TB epidemic. But the global TB epidemic response has mainly been more of a gender neutral, universal access, focusing on biomedical efficiency rather than this kind of really tailored interventions for those who are inherently most affected by the disease, most burdened by it. And that has definitely been amongst men. So if you think about this as a rising tide lifts all boats, you can easily see how the global HIV response has been, there might be cracks in the boats, but there's a lot of these targeted interventions that have really tried to, fill in those um, the cracks in the boat. And so, the all tides lift the rising tides lift all boats. It's definitely lifted all the boats, but there's been a lot more targeting to women to sort of cover up or to deal with those cracks, but it hasn't happened amongst men. And for the global TB response, it really has been just about a rising tide lifts all boats, but there really is no targeted addressing of men's health needs. And so you might have a rising tide, but the boat is still taking on a lot of water for men. So a large portion of my work has really been focused on this kind of intersection between social norms, gender norms, and stigma in men's engagement in care and TB. So, with regards to social norms, gender, and stigma, we know that traditional masculinity norms equate illness with weakness or with failure. And because stigma reinforces this kind of silence or secrecy and emotional withdrawal from men, men are more likely to internalize their stigma that is emanating from, communities, households, health systems. And this internalized stigma a lot of times leads to poor mental health, their isolation, their disengagement from care. And there's been very few interventions, I would probably say maybe one or none, that really confront stigma from a male-centered perspective, especially in African settings. So when we think about engagement in care, we know that unfortunately men are less likely to seek care. They're more delayed in seeking care. They're less likely to complete treatment. They're more likely to disengage from care. And often the health system fails to accommodate men's unique needs and preferences. But the issue is, but why? Why is all this happening? And in informal conversations that I've had with nurses amongst a large number of clinics, I get unfortunately very either stereotypical or biased responses of, why are men more likely to delay their health seeking? Well, it's because men don't prioritize their health the way women do. Or why is there a greater likelihood of disengagement from care? And sometimes, actually, many times I've heard things about, oh, well, when they start to feel better, they just want to go back to work or they want to go back to drinking. Or, why do we think that there's a reluctance for men to disclose their illness and inherently causing them to not have access to social support. And typically, what I've heard is men don't want to look weak. And these are very unfortunately biased, stereotypical, responses for why are all of these issues happening around men. And I think there hasn't been the same type of foundational work the way the global HIV response did to really understand how do gender and social determinants really interact to impact men's health behaviors or their health outcomes. And so this is what a lot of my work is really trying to focus on, which is, but why is all of this happening? So the first project I'm going to tell you about is around trajectories and characteristics associated with men and women's engagement in TB care. So, some of this I don't really need to tell you. Obviously, South Africa continues to work with the 6-month daily um, medication regime for drug-sensitive TB. The first 2 months are intensive phase. The last 4 months are continuation phase. And there's typically these two bins of outcomes, programmatic outcomes. Either you successfully complete treatment or you don't successfully complete treatment. And within those, for successfully completing treatment, it's typically made up of these two components. You completed treatment, and this is where inherently the definition is you didn't interrupt your treatment for more than 60 consecutive days, and there were no signs of treatment failure, or cured, which assumes that you have some sort of culture test done at the end of your treatment that shows that there's no bacteriological presence of TB in the sputum. And we know that happens very infrequently, if at all. And then the unsuccessful treatment outcomes are, combination of loss to follow-up, treatment failure, or death. So now the issue here with successful treatment outcome is it doesn't really capture how many days are missed along the way. And it also doesn't allow for us to really understand and recognize the risk that still may be around for those who technically completed treatment, but they're potentially at risk for poor post-TB treatment outcomes because they've potentially missed so much treatment. And so really, why does engagement matter? And so much of the research around factors associated with poor treatment outcomes really is at the individual level and really looks at, did they successfully treat, did they successfully complete treatment, or did they not successfully complete treatment? So it's really this kind of binary outcome. And we know that treatment adherence and care engagement are very critical to achieving good health outcomes. And this is not just about health outcomes, but a lot of times the way it's looked at, it's just about good programmatic outcomes. There's been a lot of work in, there's a number of papers that are starting to show that missing 10% or more of daily doses, which, over a 6-month course of treatment, it's about 18 days worth of treatment, increases by about 6 times the hazard of relapse, failure, or death. And then there's some other papers that are starting to show how clustered missing of treatment within just 1 month could also increase the risk for poor health outcomes. So, inherently, it's, missing a day here or there might not be as bad as, if you miss a cluster of treatment every so often. And what the programmatic definitions of outcomes, what happens is it masks the type of risk that individuals may actually have post-TB treatment. And we know that men have poor engagement in care and TB treatment outcomes compared to women. And so there's been a lot of work done on adherence interventions, but we see that a lot of them are falling short. So most of them show limited or inconsistent impact on treatment outcomes. Many of them are really developed with the idea that it assumes all patients are arriving at the same poor outcome in the same way. And there's been very little data-driven approaches to actually segmenting populations of patients based on how they engage in care, not just their individual risk factors, like do they have HIV or not, their household level income, their individual mental health scores. And we know that a lot of these interventions are particularly poor amongst men. We've done some work where we looked at a deep dive of some of these systematic review meta-analyses to really understand, how many of these interventions really work well for men. And what we found was extremely few actually work for men, in that if there is any effect of the intervention, it's heavily driven by the impact of the intervention amongst women. So what we did was we had this prospective study design where we recruited people who had drug-sensitive TB, and we did this in 18 clinics around Buffalo City Metro Health District. We recruited individuals age 18 years and older, and the data that we collected was around treatment refill dates. So the expected date when they're supposed to come and the actual date that they presented for their refill. Then we also did a number of quantitative questionnaires. But for this study that I'm going to share with you, the data set that we actually used was what was the engagement trajectory of those who completed treatment. So we excluded those who did not complete treatment, just to really get an understanding of those who technically successfully completed treatment, what did their treatment engagement actually look like? And what we used latent class growth modeling on this, and then logistic regression analyses. So when we looked at the cohort characteristics, we enrolled 657 individuals, and of those 657, 548 had the programmatic outcome of successfully completing treatment. For the analytic cohort, you could see here some of the basic characteristics. Median age was 38, 67% of these individuals were men. There was a very high rate of unemployment. There was a very high rate of those completing treatment. For HIV, we saw that 63% of women in the cohort had HIV, 38% of men were living with HIV. And so when we did the trajectory modeling, what we saw was there were three very distinct classes of trajectory. So starting at the bottom, this red line represents those who were pretty darn engaged in their treatment. They missed very few treatment refill visits throughout the course of their treatment. The second curve is the blue curve, and this is those who, at the very beginning of their treatment, before 2 months, they were, again, pretty consistent with picking up their treatment on time. But starting after this 2-month period, they started to become very disengaged from care, or having much poor engagement with treatment, and starting to miss many more days from when they were supposed to pick up their treatment to when they actually picked up their treatment. And then in this third class, this gray-black line, were those who, from the very beginning, had poor engagement and poor timing for when they were supposed to pick up their treatment to when they actually picked up their treatment. So, when we think about what's in the literature, these three groupings aren't necessarily surprising, because we understand that there are individuals who, once they start to feel better, they start to disengage from care. And that's exactly what this graph is showing. And we also know that there's some folks who, from the very beginning, they're very suboptimally engaged in care. So now, when we broke this up by a cohort based on sex, what we found was men were represented amongst all three of these groups. But when we looked at the trajectories for women, either were very engaged in care, missing very few days between when they were supposed to pick up their treatment and when they actually came for their treatment, or from the very beginning, they disengaged from care and they were just missing lots of refill visit appointments. So when we looked at the average number of missed days per visit, you could start to see where, highlighted in red, if we assume that there's this, if you start to miss 4 or more days worth of clustered medication, you increase your risk. So obviously in the consistent class, they weren't really ever missing more than a day or so of a treatment refill visit. But when you start to get, especially amongst men, this suboptimal grouping after 2 months, a lot of them, the average number of days of missed treatment refills was by 4 days or more. And for those who had this suboptimal engagement, they were missing treatment refills by about 7.5 days. So now when we looked at the total accumulated missed days of treatment when they were programmatically defined as missing treatment, when they were programmatically defined as successfully completing treatment, what we see was that, in the suboptimal classes and in the class that started to miss more treatment visits starting at 2 months, and then those who were missing a treatment refill visits from the very beginning, they all had way more than 18 days worth of missed treatment refills. And if you make treatment refills as a close proxy to treatment dosing or treatment adherence, you start to see that even though they were characterized as successfully completing treatment, their engagement in care would say a different story for their potential risk. And if you look at the average number of days accumulated of missed refill dates, the suboptimal engagement in care groups are above the 60 days of, in the loss from care, it says, if you miss 60 days or more of continuous treatment, you're characterized as loss from care. But that doesn't take into consideration, this accumulated number of missed days. And so for these suboptimal groups, they're technically starting to look like they're missing 60 days more worth of treatment. It's just not consecutive. So when we started to look at what those risk factors were, or what the factors were that were associated with being in these different groups, one of the big things that really popped out was ever having it had TB in the past. So this data here is from the overall cohort. I haven't shown you what we're seeing when we stratify by sex. So in the red line, this having TB less than 2 years ago, there's a very high odds of group membership. And in blue is, we see that there was a very high odds, but that confidence interval is very wide. And even though that p-value doesn't meet that, 0.05 criteria, we're still saying that there's a moderate association. And because of the sample size, we may want to keep an eye on these kind of variables that look like they have moderate associations, even though the odds ratio is high, but the p-value might not necessarily reach significance. So when we look at what those characteristics are of association with group membership by male and female, we again see that both men and women have this, if you had TB less than 2 years ago, they have a very high odds of being in these suboptimal engagement trajectories. For men, those with moderate associations were if they were in a relationship or not, which seemed to be protective. And if they lived with children, it looked to be a risk factor. And I'm sorry, I forgot to mention that for men, being in the suboptimal engagement and care from the start of treatment, being HIV negative seemed to be a significant risk factor for showing an association with the suboptimal engagement and care trajectory. And for women, the HIV negative status seemed to be somewhat of a protective factor, but it was only moderately associated with group membership. So, some key points to mention is how programmatic treatment success really does mask some of these suboptimal engagement patterns. And it potentially could underestimate the proportion of TB patients who are at risk for relapse resistance or post-TB sequelae. In regards to the recent history for TB, this was amongst both men and women. How we're looking at it, it probably speaks to these persistent vulnerabilities that these men and women have that are likely rooted in either social, economic, behavioral health system challenges, or it might be around treatment fatigue from repeated episodes of TB treatment. With regards to men's distinct suboptimal engagement, um, the idea that only men seem to be showing the suboptimal engagement from 2 months probably speaks to some sort of gendered social economic pressures to return to work or resume some sort of normative masculine roles once they start to feel better. And again, we definitely see that in the qualitative literature. And then with regards to men's negative HIV negative status being a factor that's significantly associated with their suboptimal engagement in care, this might speak to uh, men who are HIV negative, their lack of prior engagement or less experience with navigating the health system. And a key thing to really point out is this was done amongst about 550 participants. And because of the way trajectory modeling works, where it's a probabilistic, are you in one group or another? Once you start to have larger sample sizes, you could probably hone in potentially either on more treatment trajectories that we see, or to start to increase the accuracy of those confidence intervals and starting to show that things that seem to be moderately associated actually start to show as being significantly associated. But in terms of how you think about trajectory modeling, there might be an interesting take on using that for a programmatic indicator. Um, because if you were to take the DHIS or tier data and you were to map out these trajectories, if you were to start implementing interventions, a way you could try and use these trajectory models are you starting to see a lower percentage of individuals in these suboptimal groups, or are you starting to see these kind of suboptimal groups starting to flatten out into being more consistent engagement? And so for a tool for programmatic purposes, there might be some benefits. For implications for some of this work, definitely we could argue right now that patients with prior history of TB should be prioritized for additional supports. And there's also a lot of work out there on shortening regimens. And those shortened regimens really are, these 4-month regimens. But what this data might actually be showing us is, a shortened regimen may not be the panacea because people are still either having somewhat poor engagement in care, or especially for men, once they start to feel better, they start to disengage from care. And so a shorter regimen may not necessarily address those factors. And we also know that care engagement is definitely dynamic and gendered. And this definitely speaks to how there needs to be gender informed and gender responsive interventions, especially for men. So the second study I want to tell you about is using qualitative data to start developing pathways to help us understand vulnerabilities when ill with TB. And so a big thing that we were focusing on was stigma. So why does stigma matter? So especially for men. So when you think about masculinity, masculinity is relational. So it's not just about how a man sees himself and how masculine he sees himself, but it's also about how others perceive him to be masculine and respond to him. And so stigma is a social process that labels or devalues individuals based on perceived differences. And so one thing that stigma definitely does is it reinforces these kind of social hierarchies. And there's 3 interrelated domains of stigma that I'm going to talk to you about today: anticipated stigma, experienced stigma, and internalized stigma. So anticipated stigma, you could think of it as, I just found out that I have TB. If other people find out, they might start to stigmatize me. So it's the fear of being stigmatized. Experience stigma is really about discrimination. So, let's say you're HIV positive, your family kicking you out of your house, your partner breaking up with you, being fired from work. Now we know that hopefully is not happening as much or at all with HIV, but we're definitely hearing from men the idea of being fired from work or being let go from work because they have TB. And then there's the issue of internalized stigma, which is really, I deserve this, I did something wrong, sort of blaming themselves for having had contracted TB or HIV. And with regards to the impact on men's behaviors, so stigma will mark men as being weak or somehow morally compromised. And again, being perceived as ill may trigger gossip or loss of respect. And some of these things really aren't necessarily specific for men. It could also definitely happen and does happen for women. With regard to men, stigma also erodes their social ties and resources that they might rely on. Um, and again, these types of things will also happen with women, but how stigma and gender interact isn't as well understood. So what we did was we were trying to answer the question, how do men and women living with TB or TB HIV in South Africa experience stigma and isolation? And how do those experiences impact their access to resources that they need during treatment to be more resilient in complete treatment? So what we did was we did a massive number of qualitative interviews. So we interviewed 142 individuals, and we did this in three main categories of individuals: those who recently completed treatment, those who are currently engaged in TB treatment, and those who are at risk for being lost to care. And the way we defined the being at risk for loss to care was individuals who missed 15 days or more of a treatment refill. And we interviewed both men and women. And so for the qualitative work, what we had done was we used the behavioral framework of the network individual resource model. And I'm happy to talk to you about that more later if you have questions. And this model was originally developed for HIV prevention, as a behavioral framework for HIV prevention. And a key thing that we were looking at were concepts of isolation. So there's really two concepts of isolation. There's social isolation, which is when someone removes themselves from an environment, and then social exclusion, where someone is forced away by other people. And then we were looking at domains of stigma, anticipated experience, internalized, and I could talk to you more about the exact qualitative analyses that we did. So what I'm going to do here is, as I speak to you and show you the quotes that operationalize some of the themes that we identified, I'm going to start building for you this pathway that shapes vulnerability and resistance that seems to have a very gendered aspect to it. So one of the first things that starts to happen is men and women describing this kind of anticipated or internalized stigma because of their TB status. But a key thing about being stigmatized is you need to start showing some kind of mark that identifies you and then allows people to identify you for stigmatization. And for TB, a big thing that people were talking about really was about the visible weight loss. And I'm going to share with you some quotes that I had my staff do voiceovers. So the voices that you're going to hear are not of the actual participants, but of staffs doing voiceovers.
I get embarrassed. Maybe, let's say, we are chilling at a certain place. Let me make an example. Let's say I'm on my way to town. We are sitting in a taxi with people or any other place you can think of. Or maybe I'm visiting a friend at his home, but any place I don't normally go to. I do feel embarrassed. Hey, people will start asking questions here about my loss of weight and other things that I won't be comfortable to talk about. So I end up not going to these places because I'm ashamed and scared.
So that's a quote from a man. Let me share with you a quote from a woman.
I was thinking about what people will say. People will be watching me when they pass by while I was sitting there. I thought maybe they think I have TB because I drink a lot or smoke all those awful things. Like maybe they are judging me. I was thinking.
Okay, so what this man and woman were describing is inherently the stigma marking, which starts to kick off this pathway for the impact of stigma on their illness to health journey. So now What we were identifying with women were often describing how they would not leave their homes due to comments that they heard after exhibiting TB symptoms. And these comments were unwarranted judgment, predominantly emanating from their social networks. So let me share with you another quote from a woman.
It made me very sad. I was ashamed I couldn't even leave the house. People were talking. My neighbor was the first person to notice that I've lost weight.
So in comparison to women, men were really describing the situation of trying to go out and continue to socially engage with their friends, but how those friends would either distance themselves or actively exclude those men from social events or community spaces because they knew that their friend or this other guy had TB. And so let me share with you now a quote from a man about him being socially excluded by his social network.
They were far from me. They did not even want to come and see me. Even when I take a walk during the day and go to them, they will not want me near them. Maybe if I've gone there with something to eat, they will not want to share it with me.
So from that initial stigma marking, what men and women are describing is men are describing social exclusion. So they're losing their agency for being able to engage with individuals. Whereas women were talking about social isolation, but more as a protective reaction to not either being perpetrated upon them experience stigma or out of fear of anticipated stigma. And what the literature tells us is when people start to become isolated, either because they were socially isolating or because they were socially excluded, they start to lose resources that are socially networked. And that this kind of exclusion or isolation starts to put them down the path to vulnerability during their illness to health journey. But now a key thing is family support. And in the literature, there's a lot of the literature that describes how family support really works to improve one's resiliency. But what we're seeing is this kind of family support seems to be very gendered. So when we were asking women about family support, what women were often describing was a high level of trust in their family to disclose their TB illness to their family, and also the fact that their family was accepting of them and that the family was providing them with the resources needed to traverse that illness to health journey, and that their families were mitigating this effect of social isolation. So let me play you now a quote from a woman.
When I found out that I had TB, I came home and I told my family that I have TB. They didn't judge me or distance themselves, but supported me and changed the food we eat to healthy food for me. They did that so that I could quickly recover. When I found
Okay, so ultimately what we now start to see is family support for women starts to mitigate this vulnerability due to their social isolation from their social networks. The families provide support, they provide access to resources, and this support and access to resources inherently increases their resiliency to complete treatment. But now what we see amongst men is very different. So men were describing how not only were they being socially excluded by their friends, but they were significantly socially excluded by their families. And let me play you a quote from a man.
It is painful on my family's side, only because my mother was someone who loved me. But when I had TB, I have never seen her. She doesn't even call. And my sister is the one who changed when she found out that I have TB. She didn't give any support except the ones I told you. And the cereals she bought me once, she never bought them. And she never came again to check up on me. I wish my sister and my mother would have supported me. Because when I was working, I was doing everything for her, my mother. Now she is living well in the villages and she has money. but I am not looking for her money. But I wanted her to support me, especially with food, because I was really struggling with getting food. Because I was not working and my girlfriend was not working as well. It is
Okay, so what men in the study were describing was this loss of access to family support. And as you see now in this pathway, so their social exclusion from their social networks and their social exclusion by their family, which then causes them to lose additional resources that may be networked through their friends or their family. This is increasing men's vulnerability during TB treatment. And this has really not been described in the literature. Um, but I should also note that this is very different depending on which country you're in, because if, let's say, there's been a lot of work from India, and in India, the social exclusion by family against women if they have TB seems to mirror what's going on with men in South Africa. So what's the implications of some of this work? So really, stigma manifests very differently. The impact of stigma manifests differently by gender. And if you're trying to develop gender responsive interventions, especially around stigma, you have to tailor these strategies distinctly for men and women. For women, an intervention may be more focused on the family because the family is still supporting the woman. So supporting the household might be, an intervention that one would develop that is gender responsive for women. But for men, based on what they're saying, you wouldn't necessarily develop an intervention to support the household because the household is socially excluding that man. Um, Care models should also address both the emotional and material consequences of stigma. And specifically, I speak about how men were losing access to food resources, to financial resources, whereas women, because their families were still supportive of them, they were able to maintain those. But typically, when we think about, food insecurity and interventions, a lot of times those interventions, especially around children, is you target the mother for those food interventions. But what we're seeing here with TB is, maybe a food intervention for women may not be as gender responsive as a food intervention for men. So all of these things are things that we need to consider when we're thinking about developing gender responsive interventions for TB. So the last thing I'm going to quickly tell you about is adapting and implementing a gender responsive intervention for men with TB and TB HIV. So we had previously done work around trying to really understand what are men saying that they want and need of a intervention to support them to stay retained in care when they have TB. And what men were saying in that previous study was there were three key things. One, they wanted peer support from other men who had TB in order to navigate TB-related stigma or unhealthy masculinity norms. And a key thing with this peer support were men who are currently in treatment were saying they wanted to receive this peer support from other men who recently had TB. And the men who we spoke to who had completed treatment, they said they want to be resources for men who are currently going. So this was like from both sides, which was very good to see. Men were also describing how interventions should be delivered to them in familiar locations where men congregate. They were pretty explicit about saying, do not give us an intervention in the clinic delivered by nurses. And a third thing that they were talking about was the idea of community awareness around the challenges that men face when they're ill with TB. Now, none of these three really sound like groundbreaking, anything really new. But the thing was, when we looked through all the other TB interventions to support treatment adherence or engagement in care, none of them had this kind of peer-to-peer support. None of them were delivering interventions for men in where men were congregating. So, when you think about what I said before, where a lot of interventions for TB treatment adherence support, those that were effective, that their effect was mainly driven because of the intervention's impact on women compared to men, this might help explain why. So when we were looking around for an intervention that inherently had all the components that men with TB were speaking about, we came upon the Coach and Pilo intervention, which was an intervention developed by men in South Africa for men with HIV and developed also by men living with HIV. It really spoke to us because, again, it had all of those components that men with TB were asking for, and it was inherently locally developed. So really, it addresses potentially a lot of the cultural norms that we would need to think about if we were adapting an intervention that was, let's say, developed, somewhere else in the world. The Coach and Peel intervention was really grounded in this kind of human-centered design to align with men's lived experiences and their values and preferences. So again, it speaks to the qualitative work that we had that was speaking to what are men saying that they wanted and needed for interventions. In the Coach and Peel intervention that we've been adapting, it provides one-on-one membership with men being helped to navigate stigma, treatment barriers, health system distrust issues. And the men that were delivering the intervention were men who previously had TB. So again, it's the idea of peer support from someone who knows my lived experience of having had TB. I think I just spoke about some of this. So there were a few things that the previous Coach and Pilo intervention did not have. And one of those was, even though it was developed using human-centered design, there wasn't a proper behavioral framework for the intervention. And so we had integrated social cognitive theory into framing the intervention so that when we look at it from a rigorous scientific point of view, can it be an evidence-based intervention? Yes, no. We have this kind of framework that helps us, look at and evaluate the intervention. We also tailored the intervention for intensive phase TB treatment and continuation treatment. And this also speaks to what we were seeing in the trajectory models of men being the group that, once they started to feel better towards the end of that intensive phase treatment, they started to have poor engagement in picking up their treatment refill. So this kind of phase-specific tailoring would be really important for men. And then finally, what we also did was we incorporated motivational interviewing and photo voice storytelling. So a key thing for the coaches to be able to do with men who have TB that they're trying to support is be able to tell your personal story of what it was like having had TB, so that the men who you're trying to work with could really start to understand, this guy potentially knows what it's going to be like, or this guy knows what it's like. So that kind of photo voice storytelling was to help the men develop a good story to be able to share their experiences with. And for motivational interviewing, it also was about having men who are the coaches really learning how to listen, which would inherently deepen their engagement with the players or the other men that they were supporting. So we've been we finished adapting the intervention, and we did a pilot trial in the Mthatha area, and we had recruited men who were newly diagnosed with either TB or HIV. Again, the men who were the coaches were men who had previously completed treatment, and we were getting towards the end of recruitment, and then because of all the fiasco going on with the U.S. government, the grant came to an end. But we have definitely enough data that we're now starting to look at to analyze the preliminary effectiveness, preliminary feasibility, acceptability of the intervention. We're hoping to identify grant funding to scale this up if we see that in the pilot work that it showed to be acceptable, feasible, and preliminarily impactful. And with that, I thank you very much.
Thank you so much, Prof. Andrew Medina-Marino. It was a very insightful presentation. Thank you so much. We have just about 10 minutes, colleagues. Does anyone have any questions or a comment? A comment that they'd like to ask, Prof? Pren, you may go ahead. Let me quickly unmute. Just a second. Okay. Then you may go ahead.
Fern, I think you might still be muted.
Thanks, Andrew. Great presentations. Just two quick questions. First is, you say that a household intervention may not be useful for men, but you've also said that men don't receive the support from their families. So surely that would be the household intervention. And then I was just interested in how you actually calculated the missing doses amongst both men and women, because obviously, you know, our data on adherence in terms of, you know, even poor collection is quite challenging.
Yep. Okay, so for your first question about the household intervention, yeah, you are correct. The household intervention for men may be about getting the family to engage, getting the family to not socially exclude the men. But obviously, we would assume that the man who is on TB treatment would inherently say if he wanted that intervention conducted with his family. And so we would need to understand his preference for how he would want interventions delivered. But I agree, you know, an intervention for men might be at the household level for increasing the support that a man might get from his family. In terms of the trajectory issues, so we did not calculate the missed doses. Ultimately, what we did was, again, the key data was the day that they were supposed to pick up treatment to when they actually picked up that treatment. And so we were using that as a proxy for potentially treatment adherence or dosing, but it is not the actual adherence or dosing data. But there's a lot of literature that shows that pharmacy refill pickups is a good predictor of adherence or treatment dosing behavior. Does that answer your questions, Bren?
Yeah, thanks. Thanks, Andrew, and great work and great presentations.
Is there another question?
Yes, afternoon, Andrew.
Yes.
Thanks for the great presentation. Just one or two observations from my side. One is, I think it's the issue around the issue of the household intervention, which was raised by the previous speaker. I think looking at the household intervention, I'm asking myself the question, is that we may need to find out what is the perception of the family and not the I, because I think I've joined a bit late, but in most of the quantitative interviews that you've done, the responses were mainly from an I individualistic perspective. I would rather think that one should start to change the pendulum by asking to families, why are you behaving in a specific manner? But I think that's one observation. The second one is that I actually want to move to a point where we need to look at these studies from an Afrocentric perspective, meaning that we get less of the I and the more of the we. And then looking specifically at how you look at the gendered approaches, because I think the family, it's central when you look at a commonality Afrocentric perspective of the family as the base. Now, if you look at the men, they also form an anchor in the family. However, that same family can also lead and guide men and actually yield them around this issue of looking of getting treatment or actually disclose their status. So I think for me, it's important for us then to look at these studies also from a different angle. I think those are my two observations at this point in time. I just want to get a view around that. Thank you.
Yep. So I should mention, we did a large number of interviews also with the caregivers that TB patients were identifying. So we asked both men and women who are currently engaged in TB treatment, who were their primary supporters, and can we go speak with them? So we have a lot of data from that aspect as well. I just haven't presented it here, and we're still in the process of analyzing that data. So we did get the perspective of the households where we were allowed to speak with them.
Thank you, Prof. Marino. Prof. Levina, you may go ahead.
Hi, good afternoon. Thank you for the great presentation. Good to see the results. What was not clear is whether the men had internal stigma, or is that how their families really treated them? Thanks.
Men, I have to go back and look at the data, but I don't remember men talking as much about internalizing the stigma about, oh, I deserve this. I drank, I was walking around, of course I'm going to get TB. We didn't hear as much of that. There was a second part to your question. I can't remember, sorry.
Prof. Levina?
Yeah, no, it was more about, was it internal or the reality of how their family treated them after they had TB that made them feel they.
So obviously we did a lot of interviews, and so there's some variability, but when we were looking at the themes, these were the themes that were popping out. But amongst the men who were saying that their family were socially excluding them, I want to say out of I think we did about 90 interviews with men, 85, 90 interviews. There were about 12 men who very clearly said, I was locked in my room and I was not allowed to come out. And I would have to pee out the window because I wouldn't be allowed out if there were other people in the house. Like, that is pretty explicitly discriminatory. That's pretty explicitly experienced stigma. And so men were pretty explicit about what was going on. Another key thing was a number of men spoke about having it lost their relationship. One man was describing how the nurse in the clinic was his wife's sister, and once the wife found out, she wanted a divorce from him. And so losing relationships was definitely something men spoke about. Of the 60 interviews that we had with women, 0 women spoke about losing their relationships because they had TB. 0. So, I mean, men were pretty explicit about their experienced stigma.
Thank you so much. Grant, you may go ahead.
Thanks, Andrew. That's a really wonderful series of projects. What implications does this have for household contact tracing? All right. I mean, I'm thinking about how challenging it is to get people diagnosed with TB to, allow their contacts to be tested and even potentially treated, including for TBT. I mean, how do we factor in your findings? It seems like more efforts need to be put into getting the contacts of men referred, given these challenges.
I agree. Now, the interesting thing is we've looked at some of the data for, of TB patients who don't agree to a household investigation. We didn't see any major difference between men and women who refused a household engagement. What we did see was more men saying that they lived alone. And so, one assumes you just believe what someone is saying. If they live alone, they didn't have any household contacts, and so you're not going to ask them to do a household contact investigation. Now, when we've gone out to households, we still see the same thing, that if you look at the current national TB testing database, even though we went to houses and there were more women at the houses, we still found more cases amongst men. absolute and proportion. So I wouldn't necessarily discard household contact investigations as an appropriate way to still identify cases, including those amongst men. But I think there are also social network approaches to trying to reach men for testing who may be at increased risk. Or the ways I know other folks are doing, and we're trying to do it also, is do more community-based testing in community spaces where men are more likely to be at, whether that be at, you know, taxi ranks or maybe at sporting events. People sometimes talk about bars, but I'm not going to go testing someone at a bar. um, so, I think household contact investigation still has a good place in case finding, but I do agree that we need to be thinking about different ways to continue to try and identify men with TB out in the community.
Thank you. Ruth, you can go ahead, and thereafter, Julie, you may ask a question.
Thanks, Prof Andrew, for the great work. I'm particularly interested in the coaching pillow as one of your recommended strategies that you can use. In the TB context, given the risk of transmitting resistance among index TB cases, how would you recommend it being adapted for male patients specifically who are diagnosed with TB? Thank you.
So are you asking how might we adapt coach and pillow for men who have drug-resistant TB?
Yes, and also given the fact that especially for rural areas, it may not be possible to do it through social platforms. It might need to be in person. But then, how do we deal with the issue of resistant TB? Thanks.
Okay, so first off, all the work that we've done on the Coach and Pilo study has been face-to-face. If there's any, next frontier, it might be how do you adapt what we currently have to it being more on a mobile virtual platform. And in terms of, fear of drug resistance, maybe between, transmission of drug resistance between the participant and the coach. I think there's good ways for using personal protective equipment, either it being a mask or having more of that kind of social distancing. We've asked our coaches how they feel about their safety and security about potentially being reinfected, and we're looking at that data now, but we have not heard any inherent fears from our coaches about, hey, this guy had a +3 on his smear, and I'm really worried about sitting in a small room with him, because the coaches always meet the players or the participants, in well-ventilated areas. So we're doing things to try and mitigate that kind of, worry about transmission. I think we have one last question from, I think it's Julie.
Julie, yeah.
Thank you so much for a very interesting talk. I'm from the pediatric space, so I was a little bit interested and a bit concerned that you said that, if I heard correctly, having children in the home was actually a negative factor in how men finish their TB treatments. I just want to know if you feel that if there was any explanation on why you think that might be, and if there's anything that we can do about that, because obviously having young children around with someone who's struggling to complete their treatment is a bit concerning. Thank you.
I really appreciate that you picked up on that, because we just submitted a paper looking at the experience of either being a mother or a father when you have TB. And what we were finding the men saying was to try and not, transmit TB to anyone in their house. They were leaving their house to go live somewhere else so as to protect their family. And so as soon as you do that, you could start to immediately hypothesize, well, if you're removing yourself from your support system, you're going to potentially have more difficulty in completing treatment. None of the women who were mothers spoke about leaving the household as a way to protect their household or their family. So it was a very unique thing that we were seeing amongst men about the issue of children. And so that was what we picked up qualitatively. And when we picked up this quantitatively, well, then if you start to assume, well, qualitatively, if this is what men are saying, this might explain what we were seeing quantitatively.
Thank you very much, Julie and Prof. And just lastly, Prof, we have a comment, almost also question from Garang, who says, these are very useful insights, and he thanks you. And then he poses, it would be useful for us as a collective to think about what should the delivery model look like to reach more men and to keep them engaged, to learning from all the lessons shared. So would you like to also briefly respond to that before we end the session?
Yeah, so in the study that we were looking to understand, what are men saying that they want and need of an intervention, we also did a discrete choice experiment looking at what are the components of the intervention, what are the modes of delivery of that intervention. And we didn't necessarily get a clear response. Inherently, what the discrete choice experiment was saying, which is kind of a no-brainer. Some people preferred to have services and interventions delivered in the community, and others wanted it delivered in the clinic. And others were kind of, you could do it either in the community or the clinic. So the discrete choice experiment didn't necessarily shed the light we thought it would, but men in the qualitative interviews were pretty clear about, in terms of delivery, do not deliver it to me in the clinic. Deliver it to me in the community where I'm more likely to be, where men are congregating. Like that was their very clear recommendation to us. And again, the delivery would be, and the intervention should be delivered by a peer. So inherently another man. When we looked at the data for women, I don't remember any of the women talking about having a peer supporter of another woman who was not necessarily in their family. They were talking about support from their family themselves. Men were pretty clear about this peer not necessarily being from their family. So again, it's this very distinct. Women are receiving support from their family. Men are saying that they want support from someone else and not necessarily expressing that that support needs to be from their family.
Thank you so much, Garang. I hope you're answered. I have unmuted you if you'd like to say a few words.
No, thanks very much, and Andrew, thanks very much for the report. Really, really useful. I think, not something we need to solve for all of this right now, but Andrew might be very useful, to just take a step back and think about what are the tweaks. I fully recognize that wholesale changes are very difficult in a complicated system, but like what are the tweaks that could be made, I guess, to each step in the process, to get women engaged and to retain them in care. I know that's the bottom line, and I guess it goes without saying, but it'll be perhaps useful to glean on your insights to think about what can be done in a realistic way. Thank you.
Yep. Happy to continue that conversation with you.
All right. Thanks more especially to our presenter today, Prof Medina-Marino. Thank you so much for your presentation. And thanks to our attendees. And thank you again for staying on just a little bit longer than expected. And do please enjoy the rest of your day. See you next month.
Thank you very much, everyone.
Thank you, Prof.
Bye.
Bye.